I'm Dr. Demetrio J. Aguila III. I'm a peripheral nerve surgeon, I'm an ear, nose, and throat surgeon, and I'm also a plastic surgeon. I'm the host and founder of the Direct Care Movement podcast, where we dive into the intricacies of direct care, whether it's direct primary care or direct surgical care. You can find out more about what this movement is and where it's going and where it came from. I'm excited to welcome Dr. George Ozoude onto our podcast today. George, it's good to see you.
Hey, thank you, Demetrius. It's great to be back. Great to see you again, and connect with you again. And I'm really happy to be on your platform and sharing my story. So looking forward to this.
Well, we're excited to have you on board today. George Ozoude is an orthopedic surgeon in the Houston area. Is that right?
Yes, sir.
Yeah. And he has what I like to think of as one of the most innovative practice models of any surgeon that I know anywhere. There's a big movement, a lot of talk these days about direct primary care, but I don't think there's a whole lot of attention being paid to direct specialty care, and particularly direct surgical care. And I'm looking forward to diving into that some today.
Likewise. Yeah.
Thank you, George. George, why don't you tell us a little bit about yourself?
Yeah, absolutely. So as you mentioned, I'm based in Houston, Texas. I was actually born here, but raised in New York City. And so I still consider myself a New Yorker, but I've converted into Texas and Houston being my hometown now. I've been back here since 2013. Before that, I was in medical school and residency in Chicago for 9 years at the University of Illinois. And then I did my fellowship here in Houston at the University of Texas and Baylor. It was a combined fellowship. And, once I got here, realized I really wanted to stay here for my career. I did a fellowship in sports medicine, and I saw the great opportunity to be a sports physician down here in Texas. It's a great culture for sports, starting from a very young age, and, really got me excited about planting my roots here. So it's been, 10 plus years here now. The first 7 of which I was employed with the University of Texas, where I did my fellowship. And I had that experience as an employed physician, team physician, out in the community, and saw the writings on the wall. And eventually, and we'll talk about this, we'll eventually talk about my journey into private practice. And I'm the owner of and founder of a direct surgical practice here in Houston for the last 3 years now.
Awesome. So let's back up a little bit. So talking about your years as an employed physician, what did that feel like? And what was it about that attracted you when you were in fellowship? And what was it about it that made you decide, you know what, maybe this isn't the right thing to do?
Yeah, I actually had the idea of ascending the academic ladder. And that's what really attracted me to that type of employed model. I had, an idea of what that would be like from the very beginning, from medical school, maybe even before then, definitely from residency and fellowship as you go through the actual training in the academic setting. I had an idea of what that could look like. And so that was my goal. And the experience was such that I was placed within the community at one of the satellite hospitals from the main hospital, away from the main hospital, and got a chance to take care of athletes, got a chance to have my own high school teams that I was taking care of, really got a chance to experience the side of medicine that I really don't think you get to appreciate when you're in training. You're the actual last line of defense. You're interacting with patients at a different level. You're thinking about them differently. You're really investing. You're out there. You're finally done with training and trying to, become the best doctor you can be. And then you start really feeling the red tape. So, as good as you feel all those positive things, you start amplifying the negative sides of the corporate medical model. And, I started seeing all the challenges with patients either getting access or not getting access, really busy schedules, packed clinics, minimal time spent with patients. And my specialty is one where we deal with a lot of acute injuries, but we actually also treat chronic injuries as well, chronic conditions of the joint. And these are conditions where there's multifactorial reasons that go into why they've developed these conditions. And so I noticed that I needed more time to actually truly treat these chronic conditions, and I didn't have that. So I started seeing these frictions. Of course, I started seeing the frictions of prior authorizations and denials and, delayed care, and, how that impacted patients, even with acute fracture, injuries, things I really didn't, appreciate as much when I was in training. And so while it was a great initial experience in terms of I had support, I had a big faculty that I can lean on and talk to, and I had a stable, setting, right? I had a salary, right? So even though all of those things were great, the downsides were so impactful to me that it caused me to start looking for other ways, ways that I can imagine my practice. I started shifting, thinking that maybe this academic route isn't for me if there's no other way to do it other than through this corporate medical model. I still would love to teach, still would love to be around young minds, and I think that's what this podcast is about. But I realized within about 2 to 3 years, I'd have to reimagine what that looked like, and then I'd have to work really hard to try to create that reality.
Sure. So now, there are a lot of people listening to this, whether it's fellows or whether it's people who are, recently out of training. And I imagine some of the people that are listening are people who have been out there, doing the slog for a number of years already. And they like what you're saying, but they're terrified, and at some point for each of us, whether it was you or me or Dan, or any of a number of other people, we reach that breaking point, beyond which we're like, I can't do this anymore. What was that point for you? What pushed you over the edge?
Yeah, I actually remember, there's obviously many, straws that eventually broke the camel's back. Broke the camel's back. And I'm sure you can remember many instances, but I particularly remember the day I had a full surgery day, and I was just finished with my first case. And I was walking out to the parking lot to get, I think it was my phone charger, to keep my phone charged for the full day. And on the way back in, I walk past a middle-aged man with his young daughter playing outside in front of the surgery center. And they say hi to me, in a way that kind of felt like they knew me. It wasn't just a regular hi by of strangers. And I walked by them and said hi to them like there was a stranger. And I get to my second patient and look at the rest of the board, and I realize I just walked past my third surgical patient for the day. And I didn't even remember. I didn't even realize who he was. I had just seen him about a month ago and booked him for surgery. And then that really, really hit me. It's like, wow, I am not connecting with my patients, which is the reason I went into this. And the reason I think that medicine is so powerful is because we connect with our patients. And so I knew at that point, I was just so disappointed with the system, that I felt kind of fostered this type of interaction or lack of interaction. And so I think that was that moment that I'll never forget. That's the most poignant moment that I can remember. Interestingly, this gentleman, he had a very straightforward surgery and everything ended up okay, but he did have an initial post-operative issue with his dressings. There was like a stitch that wasn't fully put in by my assistant, and he had some bleeding on his dressing. And it's kind of like these patients can have complications, and the lack of the connection can actually be a liability. It can be a risk. It can be a heightened risk. I obviously called and checked in on him, but if they don't feel that connection and they don't feel like the doctor's in their corner or doctor really sees them, that can end up being, amplified. And so that really struck me that day and that night, even more so, when we had the phone call, I realized I need to be connecting with my patients. I need to create a reality of my practice, a new reality of my practice where I have a better opportunity to connect with my patients.
Sure. So what you're really getting at is that your experience was that increasingly it was dehumanizing you.
Yeah.
What is it about medicine today and surgery in particular that ends up leading to the situation where, you know, you don't have that human connection anymore? You just become a widget maker in the assembly line.
Yeah, it's a time factor. You know, it's the structure of the model has just created the framework where the only way to survive in it is to fill your clinic up with volume. And therefore, on the other side of that equation, your time with each patient will, have to go down. Something has to give. And so I think that's the biggest factor. I think there's a bandwidth challenge as well. You know, it's not just a matter of spending 30 plus minutes with a patient, but you have to be kind of really healthy mind, body, spirit to engage in your patient, really listen to them and teach them and guide them. And so the bandwidth is drained when you're dealing with all these external and non-direct clinical aspects of your day-to-day, prior auths, peer-to-peers, the meetings, the academic meetings, the institution meetings, the hospital system meetings, right? So when you're balancing and juggling all that, it's draining bandwidth from what we need, where we need to be applying it the most. And that's in the patient room. We need to have the optimal bandwidth at that point in time. So I think that's what leads to this. That's what led to that circumstance and that situation. And I think it's fixable. I'm really excited about ways to kind of solve for this problem.
So what are the components that are broken that need to be fixed or replaced or bypassed?
Yeah, ultimately that framework is rooted in how we pay for healthcare, how patients pay for it, how employers pay for it. It's structured in a way that, insurance companies control the flow of the reimbursements, the money that's used to pay for care. And, with that setup, it's a setup for disaster, unfortunately, because now practices can either be shortchanged, being paid 10 cents on the dollar, 30 cents on the dollar of what they actually, provided in service, or the payment, the distribution, the reimbursement can be delayed or not paid at all, and so, or clawed back, which is now the new thing that practices are dealing with, is insurance companies coming back after reimbursements have been given for care and clawing back for whatever reason they determine is appropriate. That's what makes this system so hard to deal with, is because practices can't, structure a clinic where they can have enough time to see patients because they're running on such thin margins due to that financial setup, that financial framework that's been, cultivated over the last 40 to 50 years. So it's not sustainable, it's getting worse, which is the scary part, and doesn't look like it's going to turn around. It looks like it's going to continue to spiral. But that's essentially how you get to the point where a practice has to go with the volume model. They have to see patients as much as possible. They make up that loss of margin in volume, right? And in time and bandwidth.
Sure. So, you're talking about this hamster wheel of healthcare and surgical care, where we all feel like we're just running, and there's no end to the treadmill. I talk to medical students and I talk to residents these days, even before they get to fellowship, and they're already talking about burnout and moral injury and, what's my backup plan for when I'm done with medicine, because I know that it's going to burn me out and I'm not going to be able to do it anymore. I mean, I don't think any of us went to medical school thinking, okay, I'm going to do this for a few years and then go do something else. Now, you have found what I think is an amazing mechanism to bring together a whole bunch of different interests and strengths and talents that you have. And I mean, we on this podcast we talk about thinking outside the box. Well, you haven't thought outside the box. You've thrown away the box. Um, Tell us more about the solution that you've come up with to all these questions and concerns.
Yeah, kind of, piggybacking off that framework that I just described, I realized that a big component to that is the lack of transparency. And it was around the time that I started, wanting to find a new way to do it is when I found, Keith Smith and the Surgery Center of Oklahoma. And this was just a new idea to me. I didn't think, anything like that existed, but you can have a prosperous, stable model going through a transparent, free market type of business model. And so I felt like that was the way to eliminate the middlemen, the insurance companies, the pharma companies, the government, from getting in between me and the patient. And so I've bought in. It made sense to me immediately. Like, this is the way it should be. There should be no one in between. There should be transparent pricing. I'd like to, see if that can be done for the surgical model in a private fashion, in a solo fashion, hopefully growing my practice in the future. But right now it's solo. And, I got inspired, and I started learning that DPCs were doing it, these primary cares, and it makes a little bit more intuitive sense for that side of medicine because there's continuity. But, you see dentists doing it. You see chiropractors doing it. Plastic surgeons, of course, aesthetic surgeons are doing it. So, I really started thinking the majority of what I do it's traumatic, but it's not necessarily life-threatening, emergent, or for a lot of times, not even urgent. We can wait, we can shop, we can kind of take our time and figure out what's best. And I think that's 85% of medicine, even on the surgical and specialty side. There's only 15% that's either catastrophic or life-threatening, emergent, or congenital and chronic, lifelong. The rest of the care that I provide can be, transparently, priced and shopped. And so I really wanted to figure out how can I make that model work. But I also realized that I probably would not, at least in the very beginning, be able to figure it out fast enough that would be the only thing I can do. Right.
Sure.
How do I extend my runway? And to me, that's when the idea of having alternate streams of income outside of my clinical, productivity is the key here. I need to have things that are paying me while I sleep, that are, making passive income. And so I started looking at different asset classes to invest in. First, as a limited partner, where I would find groups that invested in real estate. They invested in apartment buildings, medical office buildings, various different asset classes that provided monthly, quarterly, or yearly cash flow. Started taking my active income from my W-2 with my employed position and started funneling it into these assets. Started making returns on it, really got inspired, and got to the point where once I started my own practice, I felt like I wanted to also bring other physicians who I believed were feeling the same frictions into that same space, and, created a business model out of it. Created a private equity capital raising company, an investor relations company, to partner with folks who I've done investments with myself starting from 2016, and bring other groups of physicians into those investments. And that allows me to even scale bigger into bigger projects. Because, when you're working alone, it's your capital is only limited, it's finite. But when you're pooling capital, you can have a bigger, target for asset classes to go after. And so I combined, that stream of income. Also, as I started my private practice, I realized the power of locums, this flexible work model where I can choose where and when I work part of the month. And so I do that. At this time, I spend 10 to 12 days outside of my own practice, and that's an additional stream of income. Now, that's active, and I recognize that, but it's a great option because it's flexible. And so now I'm able to continue feeding these other two businesses, my private practice, my direct pay practice, and my capital private equity company. And so, it's still early. It's 3 years for both of these companies, and 3 years since I've been doing locums. But I really love where it's headed. It's going in the right direction. We still have a long way to go, but I think this just is a powerful way to support yourself while you're getting your practice going. So that's kind of my angle. It's use alternate streams of income to support your main passion, right? It almost is, it's like I want my private practice to almost just become my hobby. In time, these other forms of income will surpass what I make as a physician. And I'll really, truly just practice for the art and the science of medicine.
Sure. So, when I talk to these medical students and these residents these days, and they talk about burnout, they talk about, I sometimes hear them talking about investing, whether it's real estate or other vehicles, and they see that as a way out. But that's not what I'm hearing from you. I mean, what I hear is, I'm learning to do all this other stuff so that I can double down on my passion, so that I can be the doctor that I want to be. And so tell us how this thinking outside the box, throwing out the box, tell us about how that has affected your perspective on burnout.
Yeah, honestly, I think it gives me and everyone else just new life. Like there's an option, because that burnout, that moral injury more than anything is real. And you really kind of, unless you are aware, you really feel like there's no other way. And I think that's what you're alluding to is a lot of young students, mine and young physicians don't really know what else they can do. But I think these thinking outside the box just gives it new life. And I tell this to young minds. I tell them, I still would recommend you go into medicine. It's a great field. I don't think it's going to get disrupted to the extent that other industries are going to get disrupted by technology, at least not in the near term. And I think all you have to do is reimagine it. I think we've failed to kind of teach them other than the corporate model. But if you reimagine the ways that you can use your MD, you can leverage your MD. We haven't even, scraped the tip of the iceberg with things that you can do. This is just me leveraging my MD to pull together other physicians and invest in cash flowing assets. But you can do medical legal, you can do, medical writing, you can, be a consultant. So I still recommend young minds going into medicine, and thinking outside the box is a breath of fresh air for folks who are burnt out and for folks who are experiencing that moral injury.
Sure. So as we think about this, we think about your direct care model. We think about not using insurance, because that's really what we're talking about here, right? We're talking about stepping outside the insurance model, creating a parallel economy that is free from insurance.
Yes.
So when I talk to other physicians, regardless of where they are in their careers, those are the people I get the most pushback from. It's not from patients, it's not from employers, it's not from any of these other groups. I get the most pushback from other physicians, and it usually comes in the form of some question like, well, that's great, that you can take care of all these really, really rich patients that can afford really expensive surgeries. Why do you hate poor people so much? I imagine you get that same question.
Yeah, it's a lot of confusion, just misunderstanding. I always follow that question up with the fact that I've taken care of mom and pop, owners. I've taken care of, medical tourists, folks who come in from out of country for their medical care. I've taken care of, obviously folks who have means, but that's not all. You have entrepreneurs out there. You have folks who just can't afford insurance. And I really try to highlight that the system that is currently in place, the prevailing system, is also kind of really limiting access to, those in the poverty class and those in the lower middle class. It's very restrictive and prohibitive. So I feel like this model actually opens up access. It opens up more doors. It's not perfect. And I don't think any system will ever be perfect. But I actually truly feel, and I think a lot of us agree, that it's the best system for allowing the most access to the most amount of people. So I'm happy to field that question any day, and I think there's a lot of us that will attest to that. It's not just for rich people. The other side of it is, we all know in this space that the majority of the country is they're employed by self-funded insurers. 65% of the country are self-funded are self-funded employers. Therefore, it's not just rich, it's everyday workers. Those folks are paying cash in essence. They just may not realize it. So again, it's just a confusion and a lack of awareness. But the majority of people paying for healthcare today are self-funded cash payers. It's just coming through their employers. Right. And so, I really try to highlight that fact. And you usually get a really surprised look on their face. They usually have never even heard the term self-funded,
Sure.
And it was a surprise to me as a physician. I did not know the majority of employers are self-funded, and it makes sense why. It absolutely makes sense why they would choose to be self-funded versus, contracted with one of the main carriers.
Sure. So then, as we think about this, as the young physicians who are listening to the podcast are thinking about this, I imagine some of them are envisioning some of the patients that they've seen recently, maybe somebody they saw today, right? And, maybe that patient asked them, well, am I going to be able to afford this? And of course, the standard answer, if you're in training, or even if you're no longer in training and you're in a in a private practice or a hospital-based practice, your answer typically would be, I don't know if you can afford this, but we were taught, I was taught in med school and residency that we're supposed to discuss the risks, benefits, and the alternatives of surgery with the patient, right? Well, doesn't that also include the risks, the benefits, and alternatives from a financial standpoint? And what are your thoughts on that?
I totally agree. I think I kind of joke around with some of my family medicine and primary care friends and colleagues. I was like, do you guys ever discuss financial health? Is that one of the preventative screening questions that you guys throw out there? Because I think is critical. Your financial literacy and your financial health and well-being. It's imperative into the whole, physical and mental health of the patient is just as important, and I can understand, being in a situation where you just don't have an answer for them. I used to not have an answer for them. I didn't know what things cost, but that was one of the huge things that really pushed me to this model, is once I learned about the financial risks that these patients were taking. Right? We know the stats. It's 75% around 65% of the personal bankruptcies in the country are from medical debt, and 75% of those cohort are fully insured. So it's not even that like you're safe because you have insurance. And a lot of people will throw that out, that I have good insurance. Well, the stats would say otherwise, because the point is supposed to protect you financially. It's supposed to protect your financial health. And bankruptcy is the opposite of that, Exactly. So yeah, I think it's a crucial piece, and I actually am planning on, incorporating that somehow into my practice, where, we allow for the discussions of, the finances of the decisions that they make. So they learn how to have some financial literacy and improve their overall robustness and resilience, So
Sure. So let's talk about that. Let's talk about the financial impact. Like, as an example, what was the most recent direct care surgical procedure you performed?
So we recently did a meniscus repair in a 23-year-old Division II athlete. Yes, and it was a former patient of mine, and she followed me into my private practice, and that's another thing. She's fully insured. She's D2 student, so it's not just the uninsured that we take care of. 50% of my patients are actually fully insured, and they come to us for other reasons: value, time, access, quality. So, but yes, that was the last patient we took care of on a direct pay.
Sure. So let's talk about that ligament repair. What's the, how would you compare the financial impact of what you did versus what one of your former colleagues might have done in an insurance-based model?
Yeah, it's quite surprising how wide the spectrum of financial impact that you can get on the insurance side. It's not predictable, and I think that's the problem. That patient could have gone to see a insured doctor, or doctor who takes insurance, I should say, and their bill, depending on the time of year, could have been multiples higher total out of pocket compared to what they had to pay for my physician fee, which was less than $2,000. The rest they were able to cover with their insurance. But had that been a 100% cash pay patient, they would have paid $5,000 out of pocket. So this type of care for the insured side, if your deductible's $10,000 or more, $7,000 or more, then you're actually coming out of pocket more compared to if you just came to have it taken care of on the cash pay side, the direct pay side. So I think that's a real big key point that I don't think a lot of patients and people understand, is these high deductible plans are actually really financially hurting folks directly at the point of sale, impacting their pockets. And on top of that, obviously, you're throwing in how much you're paying in premiums, how much you're paying in copays. And it even becomes hard to even truly, assess and analyze the full scale of the imbalance of value that you're getting and how much you're overpaying for that type of straightforward, basic, predictable, shoppable surgery, right?
Sure. So we spent a bunch of time obviously talking about affordability for the patient, right? Reducing out-of-pocket costs to the patient, out-of-pocket costs to the employer. Well, that sounds great for the patient, but how the heck do you keep food on your plate and a roof over your head if you're charging people 1/5 or 1/10 of what they would have been charged if they were using insurance? I mean, how does that work?
So the great way that this makes sense is because we don't need the same overhead and the volume of staffing to play in the corporate space. It's just me and a VA for now. I have a medically trained VA who's a nurse. I partner with a clinic that does a executive suite model where there's multiple different practices in one building. Again, thinking outside the box, right? Typically, we think we have to just set up shop and either buy or rent our own space for the entire month. No, you can find these alternate models where now I'm leveraging this space where I can pay by the half day or by the day. I can leverage the in-house staff that they already have built into that facility. So they have a front desk person, they have an MA, they have a rad tech. So you're leveraging all of this and you're getting economies of scale without having to deal with that huge overhead. And of course, you're not dealing with delayed payments. You're not dealing with extra staff salaries and benefits that you would have to find money for in order to just fight for the money you've already earned. So yeah, it's for that reason, that lower overhead and leveraging, alternate pathways and alternate models that allows this to work. And I think there's evidence of that. Dr. Smith in Oklahoma has had 20 plus years, 25 plus years of evidence of it. And we noted earlier in the podcast all the other practices that are doing it this way, the other disciplines and specialties that are doing it this way. So it definitely does work. Yep.
So thinking back to when you were an employed physician, how many different people did that patient have contact with as part of your visit? whether we're talking about a receptionist or a nurse or whoever else, or a coder or a biller, how many people were involved in the care of that patient when you were still in the insurance model on
Definitely.
average?
Yeah, on average, I'd probably say 7 or more, you know,
Sure.
and folks that I didn't even know who were involved, because that's also a challenge as physicians. We don't even know what's kind of happening in the back. You walk into a structured system and everything's kind of in place for you. I didn't know there's a central scheduler, there's a coder, a biller, and someone who needs to kind of fight and appeal, and that's just on the practice side. Now you still are also dealing with the facility side, because we operate out of either a surgery center or a hospital, and they have their own, coders, billers, collectors, business office people who are, explaining the insurance. You got nurses there doing pre-op. It's a lot to go through. And I think on my side where I play now, it's just me. I do have to still rely on my surgery centers. So they do have to still go through the business office there, but it's much less, involved. And we'll even get to a point where we'll just have our own bundle and the patient only has to deal with me. And I, as the practice, can deal with the facility and, distribute all of the payments to the appropriate stakeholders, the facility, the anesthesiologist, the implant companies. It really limits the friction for the patient. So
is it fair to say that in the old model, before you decided to do direct surgical care, in an average office visit, there may have been as many as a dozen people that were involved in the care of that person, versus now where you are the whole show?
Yeah, absolutely. And you can look at my reviews, and it's refreshing for patients when they interact with you more than they do with your ancillary staff. That's what they want.
Sure.
And it's clear by the reviews. I look back at them, and that's one of the common threads and themes is, I can't believe I can get access to him directly. I can get him on the phone. I can get him to respond to email. I can talk directly to him. It's powerful.
Sure. So as we wrap up here, we've talked about affordability for the patients. We talked about how by running a lean practice and reducing your overhead, you do better financially also. The patients do better because you're able to give them more attention. I mean, this is a win-win scenario. And I would imagine that for anybody listening, that's either in practice or about to go into practice, they're thinking to themselves, okay, well, this sounds great. How do I do it? What advice do you have for the people that are sitting there wondering themselves, can I do this? I mean, can they do it? Or are you just the unicorn that figured out how to thread the needle?
No, I think there's growing ecosystem where you can lean on, folks who are either, thriving or, really pushing hard and making that concerted effort to figure this space out. And I'm really, impressed by the growth of that ecosystem. So we know of the FMMA, and we've gone to those conferences. We see how much it's grown, how it's getting bigger and bigger. So there are resources out there. I would definitely recommend starting with the FMMA. I think they're the center point of this movement. And I think there's many great other movements outside of that are coming alongside with it as well. I think identifying the folks in the space on social media platforms who are championing it, like yourself, you'll find this. Once your algorithms kick in, you'll see there's a lot of voices on platforms like LinkedIn, Facebook, Instagram, that are constantly talking about this every day. And so that's an opportunity to reach out to those folks and start consulting with them and asking them questions and figuring out how they're doing it. So I think there's great growing opportunities and resources that are out there.
Sure. So then for the fellow who's 6 months away from graduation, it's probably a little more than that right now because it's, when we're recording, but they're less than a year out from finishing their training and they want to do what you're doing. What do you recommend? Do they reach out to you?
Absolutely. I'm always available to talk about this. I like I said, I want to help more physicians, whether that's get more passive income in order to free up their options or directly talk to them about what I'm doing. I'm always available. And so, yes, I do recommend reaching out. Even there's, any time is fine. A year out, 5 years out. I do think as far as like options, I still tell young minds to keep the idea open of going into a employed practice. I don't think that's off the table, but it's strategic in my mind. Obviously you're coming out of training. So there's a lot of instability there. It can be a great initial stabilizer if you have a plan to exit, like I, thought about it, creating passive income streams. But you can see what it's like, see what you don't like. You can really get into it and experience it as a full-time attending and see where you want to tweak it and make it better. I remember when I was going through my initial years, I was like making notes of like, all right, I wouldn't do it like this. I would do it like this because that sucked.
Sure.
You can take care of your loans because that's a high debt burden, with predictable income. You can get some experience as an attending, kind of develop your way of treating things. And so I think there is some benefit for surgeons, orthosurgeons in particular. We take our boards 2 years after we finish training. So you can kind of check that box off too. And now you got a nice 10-year cushion to figure out how to do it an alternate way outside the box.
Sure.
So I leave that option on the table, but in a strategic sense. But there's definitely folks who have done it straight out of practice, whether it's their own solo practice right out of training. If it's in the corporate model, there's folks that have done it that way, and that's not easy either. And there's folks like our friend Daniel Paul, who's done it the direct pay model right out of practice. So options is the key word here. There's so many people that
Sure.
have done it, different ways that you can really tap into that and start, figuring out which way might be best for you.
Sure. So how do people find you?
So best way to reach me, I'm on LinkedIn. You can find me by my name, George Ozoude, Ozoude. You can email me at my practice, info@movementorthopedic.com. My practice is called Movement Orthopedic Institute. And then my private equity group is called Time Health Capital. So you can find me on those websites as well and reach out to me through that means in that platform as well.
Awesome. Any last words of wisdom here, George?
Yeah, I think the great thing about what we talked about today is this optionality, this new breath of life. I really like ending most of my webinars and talks with that. We don't have to throw this whole profession out. Actually, I think this opens up so many more doors for us, and it gives physicians options. When you have alternate streams of income, when you have different ways of thinking and imagining how your life and your career should be, everything's on the table. You can stay within your practice. You can, stay within the corporate model, but it can look differently than if you were just reliant on that as your sole means of income. You can choose to open up your own practice. You can choose to stop practicing at all. I hope you don't. I think we need more doctors. That's why I'm doing what I'm doing. We don't need less of us. So, but it's an option. And I think that's power. It's having the optionality. And so I really encourage, and love leaving that as my last, parting advice is really embrace the idea that you have options as an MD. You're not limited to just one box.
Awesome. Well, thank you, George, for joining us. It was exciting having you here as a guest. Thank you for joining us on the Direct Care Movement podcast. We're excited that you joined us, and we're looking forward to having you join us in future episodes as we dive into more questions and more concerns and more solutions in the direct care space, whether it's direct primary care or direct specialty care. If you liked what you heard and you want to know more, please click like and subscribe and leave us a review. And don't be afraid to reach out to us directly so we can get you more information about direct care, whether it's direct primary care or direct specialty care.